in the clinic. So we tend to, as clinicians, use ultrasound a little bit different to how like a sonographer would use it. So it becomes like more of an extension of your sort of clinical assessment, as opposed to a sonographer is really looking to sort of go through a checklist. So if you refer someone for, say, a hindfoot ultrasound, they'll be just running through and they'll check ATFL, they'll just sort of run through a bit of a list, and then they'll do a worksheet which the radiologist pretty much reports on. The hard thing with ultrasound is it's really user dependent. So it depends on the skill set of the sonographer, and they've all got differing sort of expertise in different areas. So some can be really, really good in obstetrics, but MSK is not something that they're overly interested in or spend a lot of time doing. So when you're looking at certain things, like from a podiatry point of view, say forefoot things can be really complex because they're sort of small little structures, and it can be sometimes difficult to get in there. An Achilles tendon or a plantar fascia, they're really easy structures because they're pretty big and they're pretty easy to image. But smaller things like a sort of a syndesmosis, a Liz Frank, they're things that sonographers that don't have a really good MSK background, they won't be able to get that. So you've got to sort of interpret the reports with a grain of salt sometimes. So the first, what I'm going to do, we'll just bring this up. Okay, so the first, I just thought I'd sort of start. This is just a case that come in this week, earlier, only the other day. It's a healthy sort of 13-year-old boy. He's at one of the schools with a sports scholarship, really active sort of kid. He suffered an ankle injury while at football training, and he was unable to weight bear following. Saw a GP. GP ordered some X-rays and ultrasound, and the radiology conclusion was a grade 2 ATFL tear. He'd been using a short cam boot that the dad just purchased from the pharmacy. Because it was a sprain, the GP I think called and said, "Oh, it's just a sprain, sort of compression, ice, that sort of stuff." And he's now come to me sort of 4 weeks later, and the kid's still got crutches and he's not weight bearing on that foot. So the first thing that happened was the X-ray report and ultrasound report got sent through to me beforehand. So I'm looking at the ultrasound report and the X-ray report and going, that's not really consistent with the sort of type of injury. You've got this active kid who's not weight bearing on a foot. So the conclusion was, they said, look, right peroneus longus and brevis traumatic synovitis. See, that shouldn't be the first priority, because if you have a decent ankle sprain, you do get some synovitis. It's just a bit of an incidental finding. They talk about a talofibular ligament grade 2 sprain and a small effusion of the right ankle. X-ray, no abnormality. Ankle finding, specifically no plain film X-ray of an ankle fracture. So he presents, and his father's sort of concerned, look, he's still not walking on it. He didn't tolerate the short cam boot very well because it seemed to put pressure on things. So he's basically limping now with a foot just in a plantar flex position, and no one's even shown him how to use crutches properly. So he's got those short arm crutches, basically hopping around, not in a really useful manner. So just in that, we go through sort of a bit of a physical exam. So this kid's unable to weight bear on that foot, and he's hopping just to the treatment chair. He's got tenderness on palpation of the lateral fibula, pretty much the level of the ankle joint. There's still moderate edema there, particularly around that lateral ankle gutter and the fibula. He's got really restricted, because he's been in a plantar flex position for a long time, he's really restricted and there's a lot of spasm now. I couldn't get his ankle past 70 degrees without pain. Inversion and eversion are painful. There wasn't significant gross laxity with dorsal draw test, and he's got a lot of muscle weakness, but not really any sufficient atrophy. So what would you, like, based on that presentation, what sort of things come out to you? Is the patient consistent with the report? What are we thinking? Yeah. So this is where, look, this is where ultrasound can be really helpful because it's still really important. 80% of your history is 80% of your diagnosis is really in the history. So taking that really thorough history and understanding that sort of demographic, you've got this really active kid that's not walking, right? That's abnormal, particularly for like a grade 2 injury. This is a sort of injury that even when you do it, you should be able to weight bear pretty much. Look, it might be tender that night, but at least the next day, we should be able to weight bear on it. So ultrasound is really helpful because this is just clinical ultrasound. I have a look at it, I've done that assessment, and the first thing that comes up is there's a fracture here somewhere. I'm going into that, you got a kid that won't weight bear. That's what I'm looking for. So the first thing I have a look at is the front of the ankle joint. And this is, we're looking at our ankle joint like this. So this is the tibia through here. We can see the little epiphysis there. So there's a bit of a break there. And this normal sort of V shape. And this sort of fibrous tissue is what normally sits at the front of the ankle joint. So when someone has an ankle joint effusion, we get a big black fluid that starts to come out of that ankle joint. And sometimes see that on an x-ray as well. But the reason I look for an ankle joint effusion is because if someone has a significant ankle joint effusion, it really increases my suspicion of an osteochondral fracture or a syndesmotic injury, because you typically don't see a decent effusion if someone just has done a bad ankle injury. You sometimes, if they've done it like a really complex grade 3 tear of ATFL, CFL, you might see an ankle effusion, but you generally won't see it unless there's a good syndesmotic injury, really common, and also for osteochondral injury. This is the ATFL. So the way we sort of scan the ATFL, this is the ATFL in long axis. So I've got my probe sort of oriented so we can see our fibula through here. We've got our talus, which is more of a square bone. And this is across the top here. I'll show you across here. So this is my ATFL. My ATFL, and when you scan a ligament, we put it under a bit of tension so that you can see the ligament more easily. So that ATFL is thickened, but it's intact, okay? So that on its own doesn't make sense why the kid's not weight bearing. So then I move to the fibula because that's where I'm sort of interested. That's where he's tender, he's focally tender. If we have a look down here, we can see this is the epiphysis, right? This is the fibula. We're looking at the fibula in long axis. So I've got my probe sitting on the fibula like this. So this is normal epiphysis. See through here, we've got cortical lifting, we've got some periostitis, and we've got bone callus. And we've also got some hyperemia. So that's a healing fracture. Then after seeing that, I go, there's a fracture here, and we can have a look at, so I jumped on the x-ray and had a look, and you go, there's a fracture. Okay. Anyway, so I called the radiologist, and the radiologist was still trying to convince me it could be just the angle that it's sitting on. I was like, but having ultrasound, I said, listen, he's got bone callus there. There's hyperemia. Anyway, the radiologist going, oh, it's okay. It might be a fracture, but it's hard to see on the x-ray. It's not that hard to see. This is in just the AP. The mortise view, it's really nice. So it's a Slater-Harris sort of type 2 that sort of involves this growth plate. The benefit is that it's not displaced. Our growth plate still hasn't, the anatomic position hasn't shifted. So I sent him for another X-ray just to have a look, and there's that union. So the bone has started to unite there, and our new X-ray, our new report says, correlation. Oblique vertical undisplaced crack fracture noted involving distal metaphysis, right fibula, undisplaced Slater-Harris type 2 epiphysis crack fracture, right union in progress. So it's really important when as a clinician, you see often people make two mistakes. You can overtreat someone based on a clinical report, which hasn't been taken into context. And I know, that's even been coined the term vomit, victims of modern medical imaging technology. And these are when people end up with sort of, Just black, long back. Perfect. Um, so this is where you've really got to correlate that, because we see all the time people have unnecessary operations, unnecessary procedures, and it fails at multiple levels. There can be multiple clinicians that are involved, and people just blindly follow the reports. So even when I called the radiologist, he was still trying to tell me that it didn't look particularly fractured, and it's like it's not in the it's on an oblique. It's you've got cortical, you've got osseous, you've got lucency. It's a disruption in the cortex, and it doesn't extend on the same orientation as a growth plate. There's no growth plate anatomical variance that looks like that. Okay. No, I sent them back to the same ones. Because and he said, I spoke to the dad, and he said, oh, they were actually really embarrassed, and the radiologist come in and said, oh, this doesn't usually happen. It was just missed. All right, so the first part, yeah. There are. So that's where that grading, that Slater Harris sort of, it has, there are protocols on the type of injury. They sort of differ a little bit, because you can jump online and have a look at, say, the Royal Children's Hospital. Their preference is for a Slater Harris type 1 and 2, that they're in a non-weight bearing cast for 4 weeks, whereas the Perth Children's Hospital says weight bearing boot for 4 to 6 weeks. They vary a little bit, but the ones where you've got any displacement of the growth plate, or any change in the anatomy, that's when you'd want an orthopedic, because that sort of injury can cause an arrest, or problem in terms of the bone repairing, in terms of growth. So there's definitely sort of there's grading scales which you can use to work out, but really simply what you're looking at is that anatomic position maintained. For these sort of kids, my preference is I'll put them in a below knee cast for 4 weeks. I don't with kids, boots and stuff, they don't fit them properly, and they don't wear them properly, and then you end up with this, you can end up in a position where you've got these kids that end up with, like, the pain persists for longer than it should, because he's in this maladaptive pattern. So now we've got sort of bony union, but the kid's still in a lot of pain and won't weight bear on it. So the focus is now I'm actually getting him to, focus. We're basically plantar flexing, and I'm actually putting back in normal shoes. I've left the crutches with him, but I've shown him how to use it, and I actually want him to put 50% body weight through the foot, so it's sort of supported. And then the aim is, I've spoke to his dad, we want to get rid of the crutches next week, right? But in the meantime as well, because the nervous system gets ramped up a bit because he's been in pain for 4 weeks, I said you've got to sort of settle that down as well. So things like gentle massage over the area, using a heat pack, using physio cream, tiger balm, all those sort of things, just to try and turn down that pain response. Those are really simple things, but they're actually really important sometimes. Just that sort of physical touch. So I've talked. He can't. He's not. I'm not. I don't have him in a boot. I've just got him in crutches. But he has to weight bear with the crutches. So what I've told him is I want about 50%, because we've got sort of union there. So we got the alignment's maintained. So that's why I wanted the follow-up X-ray, because he hadn't been properly immobilized. We just wanted to make sure that it was uniting, that there hasn't been any displacement, and that it's all maintained, right? Because if that had shown that, look, we don't have union, then I would put him into a cast, right? I'm no, I'm just sort of getting him. The main thing now is I'm sort of trying to. You sort of got to shift them away a little bit. So okay, it's fractured. The the benefit when you're this age is bones heal really well as a tissue, right? So the fibula is also a non-weight bearing bone. So it's different if you're dealing with a weight bearing bone, but the fibula can be managed even with small fractures of the fibula. I tend to base it on the patient more so than actually. So if the patient really can't weight bear, I'll put them in a boot. If the patient is weight bearing with quite a bit of pain, I'll often use like a tri-lock ankle brace. You know, if we're dealing with just a small avulsion fracture or something like that, it really depends on. Whereas if you're dealing with a higher risk fracture, particularly, you know, like sesamoid issues with kids, I see those. I just go straight to a non-weight bearing cast. I don't even stuff around with orthotics or anything to start with. Like if I've got a really bad, you know, either a start of a stress fracture or we've got a problem, I tend to, just because they can really be dragged out a very long time. And sometimes it's kinder to just do 4 weeks. And then when they finish that 4 weeks, because they heal so well, they basically do 4 weeks. They come out of the boot, they've got no pain, and off they go into sport. And you know, so it's restricted. Like it takes them. You compromise. They get atrophy and they do have some restriction of the ankle. It comes back within a week or two. What I'll sometimes do is, like, one of the boys, I saw him about. This was a 9-year-old, the more recent one. Presented, and this is ultrasound is really helpful for sesamoid pathology, because I was able to just stick ultrasound straight on there and I can see we've got a crack in, you know, got this irregular bone. I can see the crack in there. So in that case, I sort of skip and we just ordered an MRI, because his parents almost needed more of the reassurance. So I pretty much said, look, I'm 90% sure this fracture. I think it's worthwhile. We'll get an MRI as a second opinion, refer him off, that come back, and then it's talking about options with them. So the preference there was, okay, we do a cast for a short period of time. 3 weeks later, he still had a little bit of stiffness and stuff in the ankle. And he come in, his mum said, I still sort of got a bit of stiffness in the ankle from the cast. The sesamoid was fine. I just did like a manipulation of his proximal fibular head, ankle joint, and a bit of PNF stretching, and it's like good as gold. I just did one session of that, you know, just to free it up, because, you know, yeah, I gave him some simple stuff, but, you know, I haven't. His mum sent me a message and said, oh, he's doing really well now, no problem. So, all right, so let's move on. We'll have a little look. We're going to go through Achilles tendon first. So what we'll just have a bit of a review of that anatomy. So we've got our Achilles tendon that inserts into the back there. When we're looking at the ultrasound, we also really like to look at the bony margins as well. So people often don't think of ultrasound as being particularly useful for bone, but looking at the bone surface that the tendon's attaching into can often be really helpful, because where you tend to see fraying or tearing and pathology is often where there's elevated load on that area. So even when someone's got a plantar heel spur, I know at university they tell you that, you know, oh, there's no, you know, the association's quite poor with heel pain. The problem is if you've got a shelf of bone and you've got your plantar fascia that is flexing around that, where they tear, like 9 out of 10 times, is the deep insertional fibers. And if they end up with plantar fasciitis, becomes pretty chronic and they end up with an intrasubstance tear, they'll usually have a heel spur and the tear is right adjacent to that, and it's because of that sort of pressure. So they are related, but this is where academics can look at association stuff, and it misses the point. And it's the same with Achilles tendon stuff. We've got this little triangle of fat here. This is sort of our retrocalcaneal bursa, and we've got this little fat wedge that comes down there. So this can appear on ultrasound, and we can see that. When we're looking at tendons, if we think about it, we can look at tendons in 2 axes. We can look at it in long axis, which is where the ultrasound is sort of in line with the tendon, and we can look in short axis as well, where we're taking like a slice through it. When we're looking in long axis, we can see that sort of fibrillary pattern. It sort of looks like a brush, effectively. When we take a short axis view, it's a bit like, you know, a dowel, where we can see those tiny little fibers. So it's pretty homogeneous, it's consistent. Tendons, when they look normal, should be pretty ovoid like that. They should be bright and hyperechoic, because collagen doesn't have there's not a lot of moisture, like a lot of fluid in there. When we get degenerative changes, we get that increase in, you know, ground substance in the tendon. It withholds more water. So it becomes hypoechoic, okay, where it becomes rounder and thicker. If we have a look through here, when we've got sort of that mid-portion Achilles tendinopathy, we get an increase in thickness. The tendon, the morphology changes in the tendon. So when we look at the short axis view, we can see that tendon becoming quite round through there. And in our long axis view, we can see that we've got our soleus that's inserting into the Achilles tendon through here. And that mid portion, we start to see this big fusiform thickening. The tendon becomes hypoechoic because we get a change in the internal structure. It's becoming more disorganized. And we'll often start to get infiltration of little neovessels in there as well. So this, in comparison, is what a healthy tendon should look like. You can see how it's nice and sort of ovoid, it's bright, it's hyperechoic. So when we use the term hypoechoic and hyperechoic, it refers to the returning echoes. So the ultrasound shoots an ultrasound or an echo into the tissue, and different tissues interact with that sound wave differently, and that's called the acoustic impedance. So bone has a really, really high acoustic impedance, meaning that ultrasound can't penetrate through it. So when ultrasound hits bone, it nearly all reflects back. So that's why we call bone as hyperechoic or echogenic, because all the ultrasound returns. Fluid, on the other hand, like blood or synovial fluid, appears as black because it has a very, very low acoustic impedance. That's why we use ultrasound gel, because it's able to penetrate straight through it and nothing's reflected. So that terminology in terms of refers to whether it's bright or dark. It returns to really how much of the ultrasound echo comes back. Here's another example. This is the difference here is this is more like on a point of care. This is like on a point of care sort of handheld ultrasound, whereas you can see on a higher grade, so in an ultrasound from like a radiology department, or even, look, that's a point of care ultrasound, but that's with the two probes and stuff, the setup there is probably around the $25,000-$30,000 mark, right? So you get what you pay for in terms of image quality. But sometimes the portability of something like this, which is around sort of the $7,500 mark, this gives you a really good image but the portability is really helpful. It's not super helpful carrying that around. But if you're in a clinic where you're doing a lot of injections and the ultrasound doesn't need to move, a good cart-based machine is fantastic. We can have a look here. This is an insertional Achilles tendinopathy. So we can see down here, this is a normal one. You can see that bony cortex is nice and smooth. We can see our Achilles tendon coming and inserting into it. It looks nice and sort of hyperechoic. It's nice and bright. You can actually see that fibrillary pattern in the tendon as well. If we compare that to this image, we can see some normal fibers up here, but we can see how it becomes very disorganized through here. It becomes hypoechoic and it becomes really mixed, like it's rather than being homogeneous and consistent, it becomes heterogeneous. And we can see some fraying there as well. But you can also see that bony, the cortex on the superior tuberosity is irregular as well. And this is a really common finding in someone like this. Okay.
So even when tendons say, you've got a tendinopathy and it's thickening, because of this disorganization, it's going to reflect back hypoechoic rather than hyperechoic.
Yeah.
Okay.
Yeah. That's because, basically, if you think about, the way I describe it to patients is if you think about rope, rope is made up of lots of little strands, little fibers that are all very tightly and organized, tightly packed together. Now, when that frays, it becomes disorganized. And as it frays, we get an increase in fluid between the fibers because that's that ground substance increases in the fiber. And that changes the actual biomechanics of the tendon as well. We lose the elasticity, the flexibility of the tendon. It becomes stiffer. So there are special types of ultrasounds or like packages now where you can actually measure the stiffness. It's called shear wave elastography. You can measure the stiffness of fibers and of different tissues. They use this with people with alcohol, liver disease and stuff like that. As they look at the stiffness of the liver to work out whether it's pathological or not. But we can do this with tendons in research as well. So from where you can actually measure and see. So we know that the tendons biomechanics change. We can see another one there. Look, this is a really interesting sort of case of, in this case, this person, we can see we've got this, we've got enthesiopathy. We've got this sort of spur at the back of the heel. We're looking long axis now on our back of our Achilles tendon. We can see their tendon coming in, the Achilles tendon coming in. We've got the enthesiopathy through there, but the tendon actually looks okay. Even though we've got this osseous irregularity and change, we can see that even the superior sort of tubercle up there looks okay. The fibers look okay. When we put color flow on, and this allows us to see microflow, it's power Doppler, we can see there's quite a lot of inflammation in the soft tissue. So this person's got like a superior calcaneal bursitis. So the treatment's going to be very different to this compared to if you were treating an insertional stuff. So a patient like this, I'm not giving them heel raises and heel lifts, or that sort of stuff. What I'm trying to do is take just pressure off the back of the heel. So this is going to be a footwear problem. There's too much rubbing on the back of the heel, and that's caused a friction. And the reason they've got that rubbing is because we've got this large spur at the back there. So it's created irregularity that's rubbing. This is a sort of an example of that fat triangle. And we can see as I'm moving the Achilles tendon, that sort of sits in there. So there's a tiny little bit of fluid in the retrocalc bursa, but that's like normal. It's a normal sort of amount. This is one that we've got larger, a lot more fluid in there. It's a lot more inflamed. So we've got a more of an inflamed retrocalcaneal bursa. This particular patient, this is an old patient who I saw a few years ago. She actually presented without shoes to the clinic. She's in her 70s, and I treated her previously for an insertional Achilles problem. She presented maybe 12 months later, no shoes on, just in socks, and she's like, she's complaining of pain under her foot, right? And the pain's been there for about 4 weeks now. Anyway, I'm looking at her walking. Her walking's not right. I'm having a feel and I'm palpating around the plantar fascia. It's not overly tender there. And this is where ultrasound can be really useful because I have a look at her plantar fascia and it looks pretty normal, right? Some age-related changes, but otherwise it looks pretty normal. And then I go, let's have a look at your Achilles tendon. And I have a look at her Achilles tendon and we have a rupture. So this is a large area of tendinopathy. We'll show you up here on this one. So this is a large this is the tendinopathy through here. This is the Achilles tendon through here as well. We've got full thickness disruption. It's sort of held by a few little strands. This is the ankle joint, the posterior aspect of the ankle joint through here. This posterior aspect of the subtalar joint, and this is calcaneus. We can sort of see when I dynamically stress it, I can pull those pieces apart. So we've got a full thickness rupture. So nope, she has no pain in the Achilles tendon. The pain was coming from, she started using her flexor tendons as her primary plantar flexors. So she had a bit of tenosynovitis in flexor digitorum longus, and because that's what she's using. So she didn't have pain in the Achilles tendon. She didn't come in saying, I've got a sore Achilles tendon. She came in saying, it hurts under my foot. So sometimes ultrasound can be really helpful because it's what you don't find. Just finding that something looks normal can be more valuable because it rules off a diagnosis and then it allows you to sort of expand. So as opposed to treating her. So if you get that, if you're palpating and you can't feel where it's tender, just because someone's got pain under their foot doesn't always mean it's a plantar fascial issue or something like that. That's it. So we can sort of see here, there's another picture, there's the back of the calcaneus, and we've got all this sort of hematoma, and it's very, very sort of angry through here. Oh, the white. So this is actually a really good point. All this white. So what happens when you have, there can be something called artifact with ultrasound. So artifact is where it looks artificially a bit different because of the physics. When you have a lot of fluid, it can cause something called acoustic enhancement. Because the ultrasound can pass so easily through the fluid, it enhances the image below and it can make it look hyperechoic. It can make it look really bright. So if you've got a lot of fluid over the top of something, it will brighten underneath it. And that doesn't mean the tissue's actually, so that's an artifact. We've got to be aware of those when we're ultrasounding. Sometimes if there's a lot of bleeding and stuff, they just look a bit mixed. You actually, if they're really acute, the only way to see it properly is you actually have to strain them. You have to put them into a stress position just to see how much of the fibers are still intact. Because if you just put it on there, it all looks so swollen and messy. Again, it depends on that it depends on that skill set. Like if they're going to there's certain clinics that are really good with MSK, and they're like your Melbourne Radiology, Olympic Park, Victoria House, Imaging Associates. Yep, they're really good. They've got quite a strong MSK focus, and their sonographers are usually pretty good because the radiologists are very MSK, so the radiologists push, and the sonographers that go to those clinics generally go because they're interested in MSK. So they're pretty good. Your average one, maybe not. Depends. So this one is really just, we're going to have a quick look now at the calf muscle. So this is a calf muscle, and just to give us a bit of so this is our medial head of gastroc coming in. We've got this intramuscular tendon, or the myoaponeurosis, right? And this is like a fibroadipose septa. We've got our soleus. Both soleus and gastroc, they look different because they're slightly different types of muscles. And our soleus is more of our workhorse. Our gastroc is, we see this nice sort of fibrillary pattern through there. It's much more organized. In terms of just from a history point of view, if you have someone come in with a calf injury and they feel a pop or a sudden type thing, it's gastroc, medial head of gastroc. If they just pull up sore after a game, they might have played a footy game or they've gone to training, and they just pull up sore and they've got this grumbling ache in the back of their leg, it's soleus, right? From a history, that's pretty much, soleus doesn't pop, like it doesn't give you that sort of, but gastroc does. Yes. Oh, okay. So this is a bit what that looks on ultrasound. Now this is in an older patient, so an older patient's muscle looks different to a younger person's. A younger person's is really vascular, so it often looks quite bright, and it looks quite sort of, it looks darker. This is almost a bit, you get a bit of more fibrosis in older people. That's exactly right. It's a bit murky. So if you're scanning like a young person, really nice images. You scan an 80-year-old, things look a bit different because of those age-related changes. So we've got our gastroc. So up the top here, we've got a little bit of just adipose. We've got gastroc coming in and inserting into the myotendinous junction, and this is soleus underneath it. So this patient was he was a builder. This is only the other week. He was carrying some chipboard. He took a step backwards, basically felt a pop, leg blew up. That night, he said, I sort of went to take the bin out, and then the leg was really swollen. I was having hot sweats that night. Went to the GP. GP thought maybe it's a DVT. Ordered a DVT scan. DVT scan come back clear, so the patient didn't hear from the GP. And then he's come in to see me with this swollen leg going, I don't know what's wrong with this a few weeks later. So I put the ultrasound on, and this is gastroc up here, and this is soleus, and we have a lot of fluid between there. That's all hematoma. So we can put flow on here and go, okay, that's not moving flow. It's not a vessel we're looking at. That's a hematoma. This is in cross section, so we're taking a slice through the back of the calf, and we can see up the top here, there's my medial head of gastrocs, there's soleus, and we've got this large amount of fluid here. We can see here, we've got that rupture, that myoaponeurosis is ruptured. We've got gastroc, which is pulled away from it, and there's our soleus through there. So I basically, I drained it. So under ultrasound, I put a needle into that hematoma because of the pressure. it was it's caused almost like a compartment syndrome type pain. So 21 gauge needle. I took out 100 ml of blood. It visibly popped down. Thanks, Tony. Cheers. Okay. All right.
I just text Jackson. I don't know where he is. So I need to get a lift back to. Are you going back next month?
Yeah.
Jackson McCosker or Jackson? I think Alicia said his kid was sick last night or something, and
Oh, you're probably not going.
hospital or something.
Oh, we did have a very high
Mm,
before we went to.
all right.
Having lots of pain in that.
That's just the last little image there, but basically this is again normal one. This is another type of injury. This is where the muscles more tear. So the myofibrous sort of aponeurosis is intact, but you've got the medial head of gastroc pulling away from it. So this is like a really common sort of tennis leg. So you see how on this one it comes into a point. You get a nice organized point the fibers come down onto. See this one how it bullnoses. The fibers pull away and like retract. It's called bullnosing. It's really common because it looks like a bull's nose. And we've got this hematoma, and we've got this somatic effusion, which is basically a fancy word of saying where you've got blood that starts to sort of in the fibers. So it's like a bruising in the muscle.